I'm Ken Anderson, the director of the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston. And I'm here with the IMF at the ASH meeting 2013, where major advances in myeloma are again being announced. Perhaps the most important is the use of lenalidomide dexamethasone continuously in newly diagnosed patients, compared to using lenalidomide dexamethasone for a fixed amount of time, 72 weeks, or compared to melphalan prednisone thalidomide. The use of lenalidomide dexamethasone until progression increases the extent and frequency of response, prolongs progression-free and overall survival, and has less secondary attendant cancers. So this is a major advance. In North America, we use lenalidomide dexamethasone quite often as part of initial treatment. But outside of North America, this particular study, which is on the plenary session, is likely to be practice-changing. Dr. Palumbo has a couple of studies. For example, is comparing lenalidomide dexamethasone with 3 drug regimens in this same elderly, newly diagnosed population, and his studies support the plenary paper by Dr. Thierry Faucon that lenalidomide dexamethasone upfront and continuously is a new standard of practice. We also know from a meta-analysis that lenalidomide maintenance, whether it be post-transplant or in the elderly population, actually does prolong progression-free and with a trend for overall survival advantage. Now, pomalidomide is another drug we already have, but at ASH, pomalidomide low-dose dex is being further reported to be effective in the 17p deletion patients and to be used in combinations. So it's being combined, for example, with carfilzomib. And in that setting of relapsed refractory myeloma, carfilzomib pom dex has about a 70% response rate. So we're learning that this agent pomalidomide can be used even in high-risk disease, and it can be combined with new agents like carfilzomib. Also reported here by Dr. Richardson and also from the Mayo Clinic is the use of pomalidomide together with the other Velcade proteasome inhibitor, and there again the response rates are 70 to 80%. So new uses for lenalidomide and POM. So we really have expanded uses for both of the IMiDs, lenalidomide and pomalidomide. I think the new category of drugs, we have announced for the first time a broad histone deacetylase inhibitor, panobinostat, which when combined with bortezomib dexamethasone is better than bortezomib in prolonging progression-free survival in relapsed myeloma. And then we have a new selective HDAC inhibitor, ASH2013, which is also reporting promising results here when combined with bortezomib or with lenalidomide dexamethasone. New classes of drugs are also here. I'll just use as an example the Array compound, which is a kinesin spindle inhibitor. As a single agent, the response rates are about 25%, and when it's combined with bortezomib, those response rates can be increased even further. And the final point I would make is now that we're having all of these effective agents that can be used, we are changing our practice in 2 other ways. One is that we're going earlier and earlier to treat patients even in what previously has been thought of as smoldering myeloma. Patients who didn't need treatment previously are now receiving treatment. And Dr. Langren, for example, is using carfilzomib lenalidomide dexamethasone in those patients and achieving very high rates of stringent and even immunophenotypic complete responses. So earlier treatment. And we have a whole new area that's unfolding, the immune treatments this year. Monoclonal antibodies against CD38, daratumumab, the SAR drug, the Morphosis. 3 different antibodies to CD38 are active as single agents. Elotuzumab, targeting CS1 antigen, is very active combined with lenalidomide dexamethasone. So in the future, what you will see is combinations of agents targeted as pomalidomide, lenalidomide, the proteasome inhibitors, and these new drugs, but also in conjunction with these immune-based therapies. In summary, this year, as in the past, patients and caregivers alike can take great comfort that the advances continue. And in many patients, myeloma is a chronic illness already. Certainly that will extend to the majority, if not all patients, and cure remains very close on the horizon.